Hello, I am Sanika Kokne, second year MBBS student at Dr. Ullas Patil Medical College, Jalgaon. My topic for today's presentation is antihypertensive drugs. The subtopics are central sympatholytics, vasodilators, treatment of hypertension, selection of antihypertensive drugs or combinations, hypertensive emergencies and urgencies, and oral drugs. First off, central sympatholytics. As the name suggests, central sympatholytics are centrally acting antihypertensive drugs, in which first drug is clonidine. Clonidine is a moderately potent antihypertensive drug which is a partial agonist with high affinity and activity at alpha-2A receptors in the brainstem, mainly vasomotor center. Uses of clonidine are: it is used as an antihypertensive drug in combination with diuretics to treat withdrawal symptoms in opioids and alcohol addicts. It is used to substitute morphine in postoperative analgesia, as an antidiarrheal in diabetic neuropathy, and to reduce vasomotor symptoms in postmenopausal syndrome. The mechanism of action is: clonidine, as we know, acts on the alpha-2A receptors present in the vasomotor center in the brainstem. This causes decrease in the sympathetic outflow of the VMC, which affects the heart and the blood vessels. In the heart, it reduces the heart rate and cardiac output, whereas in the blood vessels, it decreases the PVR, causing a subsequent decrease in the blood pressure. The adverse effects are sedation, mental depression, disturbed sleep, dryness of mouth, nose, and eyes, impotence, bradycardia, and constipation. A marked adverse effect of clonidine is withdrawal hypertension. Sudden stoppage of clonidine causes withdrawal symptoms like headache, nervousness, tachycardia, sweating, and alarming rise in BP more than pretreatment levels. Interactions are: tricyclic antidepressant and chlorpromazine block the alpha receptors on which clonidine acts, abolishing its antihypertensive effects. The next drug under central sympatholytics is methyl dopa. Methyl dopa is an alpha-methyl analog of dopa, which is a prodrug. It enters into the adrenergic neuron and is converted into an active form and stored in the neuron, which means alpha-methyl dopa is converted into alpha-methyl dopamine and later on into alpha-methyl noradrenaline. This alpha-methyl noradrenaline is a false transmitter that is released during nerve stimulation instead of noradrenaline. This alpha-methyl noradrenaline stimulates receptors in the vasomotor center, causing decrease in the central sympathetic outflow. This leads to decrease in the HR and PVR and a subsequent decrease in the BP. Uses: methyl dopa is the drug of choice to treat hypertension during pregnancy due to its record of safety for both mother and fetus. The adverse effects of methyl dopa are sedation, lethargy, mental depression, dryness of mouth, headache, weight gain, impotence, and fluid retention. Some people may, however, develop hemolytic anemia or gynecomastia. Rebound hypertension can occur on sudden withdrawal of the drug. Interactions of methyl dopa: tricyclic antidepressant reverse its actions by blocking its transport into adrenergic neuron. The next class of drugs is vasodilators. It includes hydralazine, minoxidil, diazoxide, sodium nitroprusside. First off, hydralazine. It is a directly acting arteriolar vasodilator which mainly reduces the diastolic BP than the systolic BP. The mechanism of action is: it decreases the TPR and causes greater decrease in diastolic BP. This causes reflex compensatory mechanism to be activated, which leads to tachycardia, increased cardiac output, and renin release, causing increased aldosterone, leading to sodium and water retention. This can cause angina, which is usually treated with administration of diuretics. The uses of hydralazine are: they are used to treat pregnancy-induced hypertension, especially for preeclampsia. It can also be used as an alternative hypertensive in combination with diuretic or beta blocker when first-line drugs fail to achieve target level BP. Hydralazine can sometimes be used in hypertensive emergencies. However, it is contraindicated in older patients. It can also be used in management of CHF in combination with isosorbent dinitrate. Adverse effects of hydralazine are mainly due to vasodilation, which are facial flushing, throbbing headache, palpitations, dizziness, fluid retention, and edema. Angina and MI can also occur in patients with coronary artery disease. Paresthesia, tremors, muscle cramps, and GI disturbances are frequent due to hydralazine. Prolonged use of the drug can cause lupus erythematosus or rheumatoid arthritis in women or slow acetylators. Another drug under vasodilators is minoxidil. It is a powerful vasodilator with mechanism of action similar to hydralazine. Its vasodilator side effects are more, with increased risk of cardiac ischemia and heart failure. Minoxidil can cause hirsutism, which can be used to treat male pattern baldness and alopecia. The next drug is sodium nitroprusside. Sodium nitroprusside generates nitric oxide, which relaxes the vascular smooth muscle, causing vasodilation. It affects both veins as well as the arteries. In the veins, the venodilators causes pooling of blood in the veins, causing decrease in the venous return, leading to decrease in preload and cardiac output and a subsequent decrease in the BP. The arteriolar dilators cause decrease in the PVR and afterload and a consequent decrease in the BP. Uses of sodium nitroprusside are: it improves ventricular function in patients with ventricular dilation and heart failure. It is a drug of choice in hypertensive emergencies. Sodium nitroprusside is also used in arterial dissection with beta blockers like esmolol. In acute hypertensive heart failure with a loop diuretic, sodium nitroprusside can produce controlled hypotension in refractory CHF and mitral regurgitation. Side effects of sodium nitroprusside are mainly due to vasodilation, which are palpitations, nervousness, vomiting, disorientation. Sodium nitroprusside produces an excretory product of thiocyanate, whose accumulation can cause psychosis and CNS effects. As the drug causes hypotension, a close monitoring is required to prevent it from getting hazardous to the patient. After learning about the various drugs, let's move on to treatment of hypertension. The aim of antihypertensive therapy is to prevent morbidity and mortality associated with persistently raised BP. This is done by lowering the BP to a target level with minimum inconvenience to the patient. While measuring the BP, both systolic and diastolic BP can be used to predict the likelihood of TOD, that is target organ damage, which can be cerebrovascular disease, CHF, coronary artery disease, MI, renal failure, aneurysm, retinopathy, etc. The National Institute of Health and Care Excellence 2011 has classified hypertension into 3 stages. In stage 1, the systolic BP ranges from 140 to 159, whereas the diastolic BP ranges from 90 to 99. In stage 2, the systolic BP increases to 160 to 179, whereas the diastolic BP raises to 100 to 109. In severe hypertension, the systolic BP is more than 180, whereas the diastolic BP is more than 110 mm of Hg. The complications of hypertension not only depend on BP levels but also on existing TOD and other risk factors like age, family history of premature cardiovascular disease, smoking, dyslipidemia, diabetes mellitus, hypertension, obesity, CKD, and sedentary lifestyle. According to the Joint National Committee 7, there are certain compelling factors which determine the choice of drugs. Like diuretics are supposed to be given in specialized cases like heart failure, high CAD risk, recurrent stroke prevention. AC inhibitors or ARBs are drug of choice in cases of heart failure, post-myocardial infarction, high CAD risk, diabetes, CKD, recurrent stroke prevention. Whereas the CCBs can be used in cases of diabetes and stroke prevention. Finally, beta-adrenergic blockers are compelled to be used in cases of stable heart failure, post-myocardial infarction, high coronary artery disease risk. Beneficial effects of lowering BP has been established in all patients with BP more than 140 by 90 mm of Hg and has proven to reduce risk of stroke, heart failure and CAD. If the cause of hypertension is known, which could be hormonal, vascular, due to a underlying tumor, a renal disorder, etc., all efforts should be made to remove it. Non-pharmacological measures like lifestyle modifications including diet, exercise, sodium restriction, weight reduction, alcohol and smoking cessation, etc., can be tried along with the drugs. When significant cardiovascular or renal damage has occurred, lowering BP to normotensive level may not be tolerated, causing CHF, angina or edema. So BP reduction should be gradual and to a level tolerated. Now that we have known about the drugs as well as the treatment, what should be the drug of choice and how the selection is done? Earlier, thiazide, diuretics, beta blockers, AC inhibitors or ARBs and calcium channel blockers were established as first-line antihypertensive drugs. However, beta blocker was excluded from the list due to its lower efficacy in primary prevention of MI and stroke. While selecting the antihypertensive drugs, a stepped care approach, which is initially using a single drug and progressively adding one or more drugs from different groups according to need, is recommended. The step 1 is the drug to initiate therapy is selected on the basis of compelling indications, which are discussed earlier, but however, in majority of hypertensive patients who have no compelling indication, age and race are valid basis for selecting the initial medication. In young non-black subjects having higher plasma renin activity respond better to AC inhibitors or ARBs, while older patients and blacks of any age have low renin levels and show a weaker response to AC inhibitors or ARBs. Thiazide diuretics or AC inhibitors or CCB for young non-blacks are to be given, but options for blacks of any age and older non-blacks are thiazide and calcium channel blockers. Thiazide diuretics, however, even in low doses have an adverse metabolic profile. So, only AC inhibitors and ARBs for young patients and calcium channel blockers for older patients as well as for all blacks is recommended. Diuretics may be used as an alternative to calcium channel blockers in patients not tolerating calcium channel blockers and in those with edema or heart failure, in women of reproductive age and in young hypertensives who have another contraindication to AC inhibitors or ARBs or are intolerant to these drugs. A beta blocker may be used as the initial drug. Moving on to the step 2. When the target BP is not attained by a single drug, a combination of two drugs, which is AC inhibitors or ARB with calcium channel blocker or diuretic, if calcium channel blocker is not suitable, is recommended irrespective of the age or race of the patient. When beta blocker is the initial drug of choice, the second drug should be calcium channel blockers. The step 3 is including all the three first-line drug classes, that is AC inhibitors or ARBs, calcium channel blockers, diuretics together. However, before adding the third drug, the dose of the existing medication should be titrated to the optimal level or the best tolerated one. The final step is patients who do not achieve target BP even when taking optimal doses of three drugs are regarded as having resistant hypertension, which usually includes patients having diabetes and or CKD. In such cases, a fourth drug, which can either be an aldosterone antagonist or thiazide higher doses, is given depending on the serum potassium levels, or even a beta blocker. Only few patients are likely to remain uncontrolled and they require further evaluation and possible use of reserve drugs. When the BP has been well controlled for 1 year, stepwise reduction in dose or withdrawal of one or more components of the combination may be attempted to work out a minimal regimen that will maintain the target BP. However, in most patients of essential hypertension, drug therapy is usually lifelong. Next up, we have hypertension in pregnancy. A sustained BP reading above 140 by 90 mm of Hg during pregnancy has implications both for the mother and the fetus. So, reduction in BP is definitely required. There are two types of situations possible. A woman can have pre-existing chronic hypertension when she becomes pregnant, or pregnancy-related hypertension as in toxemia of pregnancy, that can be preeclampsia. BP rises after 20 weeks of gestation. In the first category, the same therapy instituted before pregnancy may be continued. However, one of the safer drugs listed below may be substituted if one of the drugs to be avoided has been used. The BP should be gradually reduced to a target level of less than 150 by 90 mm of Hg systolic and 80 to 100 mm Hg diastolic. But a drastic reduction should be avoided because this could impair uteroplacental blood flow. Women with diabetes, CKD, chronic hypertension, and history of rise in BP during earlier pregnancy are at higher risk of developing preeclampsia. So, to reduce the risk, aspirin should be given from the 12th week of gestation till the baby is born. Aspirin is believed to prevent toxemia by inhibiting TXA2 synthesis. So, which drugs can be given during hypertension, pregnancy, and which are to be avoided? The antihypertensives to be used during pregnancy are labetalol, nifedipine, methyl dopahydrolazine, whereas the antihypertensives to be avoided during pregnancy are AC inhibitors, ARBs, diuretics, propranolol, sodium nitroprusside. Moving on, hypertensive emergencies and urgencies. As the name suggests, in hypertensive emergencies, the systolic BP is more than 220, whereas the diastolic BP is more than 120 mm of Hg, with evidence of active target organ damage. Similar to it, in hypertensive urgencies, the systolic BP is more than 220, whereas the diastolic BP is more than 120 mm of Hg, with no sign of acute target organ damage. In hypertensive emergencies, the BP is supposed to be controlled within minutes to counter the threat of organ function and life. Whereas in hypertensive emergencies, this can be done over hours as there is no sign of TOD. This can occur in situations like cerebrovascular accident, hypertensive encephalopathy, acute coronary syndrome, hypertensive acute pulmonary edema, acute renal failure, aortic aneurysm. So, which drugs are to be administered during hypertensive emergencies and urgencies? Parenteral drugs. Parenteral drugs, as the name suggests, are supposed to be given by the parenteral route. Hypertensive emergencies require aggressive parenteral therapy. The mean BP should be lowered by 25% over a period of minutes or 1 to 2 hours, and then gradually to a level of not more than 160 by 100 mm of Hg. If the BP is reduced too quickly or drastically, perfusion of vital organs may suffer, leading to renal dysfunction, myocardial ischemia, blindness, etc. Therefore, fast, predictable, and short action lasting IV drugs like vasodilators and adrenergic blockers are to be used. For example, nicardipine, sodium nitroprusside, glyceryl trinitrate, labetalol, ismolol, phentolamine, hydrolazine, and furosemide. Last, oral drugs. Oral hypertensive drugs lower the BP over a period of 2 to 48 hours and may be more appropriate and safer in hypertensive emergencies where there is no threat to life or organ damage and BP can be reduced over hours. The oral hypertensive drugs are labetalol, amlodipine, captopril, and clonidine. Here we come to the end of the topic, but to test our understanding of the topic, let's take a look at certain questions. First, clonidine acts on which receptors? As discussed earlier, clonidine is partial agonist of alpha 2 receptors. So the answer is option B. Which of the following is not an ADR of methyl dopa? Since methyl dopa has been a drug of choice during pregnancy, so the correct option would be teratogenicity. Third, all are the antihypertensives to be used during pregnancy except, just discussed a few slides earlier, the answer is propranolol. Fourth, parenteral drugs to be used during hypertensive emergencies are A. Sodium nitroprusside. Which of the following is not a compelling factor for the use of diuretics as an antihypertensive drug? C. Diabetes. Thank you.